want to show another device. This is an FDA approved device called the ClearScan cover. Basically, it's a collar and a proprietary material here that is acoustically invisible. We're going to fill this full of water and we're going to push this on quickly onto the front of this probe. Again, this cover has to be in place or this ClearScan will not secure. In the situation where the ClearScan cover is pushed back onto this probe, where this parting line is, that can cause a leak. If you do notice a leak, I would get some type of stretchy adhesive tape like micropore and stretch it around here to cover that, and that will prevent leaks. Let's just fill this up. Let me show you how easy it is to fill this. It requires, again, distilled water. I'm going to fill it up to the collar. I'm going to pour it in slowly to minimize the formation of bubbles. And here's the insertion process. That's all it takes. It takes just seconds. What's important in doing this exam is to maintain a conical bullet shape to the ClearScan itself where it's in contact with the eye. I use this for aiming, especially an eye that has narrow fissures. And if it's too bulbous, it's going to roll over the lids. There's an air bubble in here, but if you do the examination, you can see it rises to the top. It really doesn't make any difference whatsoever. What's a very important concept here in doing an examination is that the pressure within this bag has to be lower than the pressure of the eye. So the eye has pressure and this has pressure. And I want to point out three advantages to using the ClearScan. One is safety, the second is sterility, and the third is comfort. We'll just pretend that my palm is in the eye. Once you insert the probe into this bag, it's no longer a flaccid bag with zero pressure in it. It's pressurized, just like the pressurized tire of your car holds your car off the ground. This is holding this away from the eye. So this gives you a safety feature because the more you push, then the more resistance there is in coming back. And if you look at your screen, if you see it's getting very close to the top of the screen, then you know you're probably pretty close to the cornea. But because of this feedback feature, it provides an important safety factor. Also, this is sterile for single use. There's a study that's being submitted to the literature, and that manuscript deals with the issue of sterility. 34 people were tested, had UBM on both eyes, looked at 4 quadrants each eye, and then subsequent to the examination, the bag surface itself was swabbed, taken to the path lab, and what was found was that 80% of all the samples taken grew out microorganisms that were associated with either endophthalmitis or keratitis. So this is a single-use device. In fact, if you just try to do the proverbial alcohol wipe for 5 or 10 seconds, it's been shown that 90% of RNA is still there. These are relatively inexpensive, and I would know that if I were a patient, I'd like to know that the bag used on me was sterile and not on the previous patient who could have any type of pathogen that potentially could be spread from patient to patient. We were talking about safety, sterility, and I want to address comfort. Comfort's a very important factor here. Because this is pressurized, if I'm rolling it on the eye like this, that the vector force is being spread over a large area. A study was published about 2 or 3 years ago, lead author Nick Bell, and we compared the use of this ClearScan bag to the open shell on the same patient. And presentation was randomized, a ClearScan or the open shell. And we had a rating scale of 1 to 5 with a little smiley face on one end and then a frown on the other. And we asked patients to evaluate which they preferred the most. And this were 35 patients who were in this study. All 35 preferred the bag, so it was unanimous. And on the numeric scale, in terms of comfort, it was, when using the ClearScan, it was right on the smiley part, around 1.5 of the 5-point scale, whereas like 2.7 to 2.9 on use of the open shell. It was deemed adversive. And in clinical usage, I can definitely attest to the fact that no patient finds this to be uncomfortable. On the ClearScan collar, there are nubs placed strategically around it, and this has a purpose of keeping the probe from rolling off onto the floor accidentally, causing a very expensive mistake. What's most important is to realize that if the pressure within this ClearScan cover, within this bag itself, is higher than the pressure of the eye, several things will happen. One, you won't get complete coverage of the eye, which is important in a sulcus-to-sulcus examination. And also, you can dent the cornea. If someone has a pressure of like 2 or 3, if they have like anterior effusions or choroidals, where the pressure is low in the eye, you can push that cornea straight down to the iris. An important safety tip, don't do that. There are 3 ways to alter pressure within this bag. One is you can change the fill amount. Instead of filling all the way up to the collar, you can put less fill in and push the probe in further. You can adjust back and forth that way, the fill pressure. A second way is to look on the side here. I can change pressure by inserting this further into the bag. I can lower pressure by pulling it out. Sometimes if I'm doing a scan, I'll see what appears to be like a furry appearance on the top of the cornea. Those are wrinkles. And to get rid of the wrinkles, and it's just aesthetics, because what's under the cornea is going to be accurately measured. But just for aesthetic purposes, to eliminate that, you can push that probe slightly in, and then they'll disappear because you've raised the pressure somewhat, eliminating the wrinkles. A third way to change pressure is by pinching this collar. This collar is more than just a sealing mechanism, but it functions as a valve also. Right now there's an air bubble in here. If I want to lower pressure or get rid of an air bubble, I can just squeeze the side of this. You saw the water escape. You can start to see wrinkles here. I can do this again. And now you can clearly see some wrinkles on the side of here. And in fact, you might want to have as little as pressure as possible in an eye that has 2 or 3 millimeters of mercury. It would appear very wrinkled and also flaccid, sort of moving downward here. And we're ready for the exam. I've maintained the conical bullet shape, which is imperative, is to put 1 or 2 drops of topical anesthetic into the eye. Look up for me. We're going to give that a few seconds to work. Okay, subsequent to the numbing drop, we're going to do an examination of the temporal angle right here. It's important. Look straight. I want you to follow my finger. If I'm looking at the temporal angle, I'm going to have the patient look slightly inward, like this. Look through my finger and find a spot on the wall. You'll notice I'm doing this examination with the patient sitting up. This is the same orientation as the ophthalmologist or optometrist might have when they're examining a patient. Therefore, that the subsequent UBM images that are captured are going to correlate more highly than if the patient were laying down. Look through my finger and find a spot. I do what's called the faux speculum technique. I want the fissures to be open, but I do not want to increase pressures within the eye. I'm going to take my left hand, push it up to the bony brow, and look at my fingers. They're curved here, sort of like a tower of fingers. I'm going to pull down with these fingers with the same hand that I have my probe. Okay, look right here. I have my finger on this ridge on the side of the probe. I'm aiming very carefully, and then I'm going to look at my screen. There's as long as it took it to get an image. Stop and freeze that. So, in looking in the screen here, before we do any alteration of contrast or brightness or magnification, here's the edge of the bag rolling off the side of the eye. Here's scleral tissue. This line right here denotes a different type of tissue, uveal tissue here, and that's a line right there. Here's a ciliary body. You can see the sulcus. Here's the iris. Here's some zonules. Here's the posterior aspect of the cornea, endothelial cell layer. Up here is epithelial. Notice there are some of those wrinkles that I had talked about before. Now, to eliminate those, you just push the probe in slightly into the bag to increase pressures. I want to do this one more time. I want to show you how to identify the angle, whether it's open or closed. That didn't hurt, did it? Oh, a little cool. Like a cool balloon. I'm pushing down. I can go way on the side of the eye. That's the big advantage here for looking for pathologies on the side of the eye. Okay, let's freeze that. My criteria for an adequate scan is I have to have a landmark in each picture. That landmark is the pupil being open. I don't want to be above the pupil or below the pupil. I always want to go through the pupil, which is evident right here. I'm going to look at the inferior angle. I'm going to have the patient look slightly up, look through my finger. The line is going to be facing at 6 o'clock down here. In my images, I always like to have the sclera on the left and the anterior chamber on the right. There's an optimal position on the screen that denotes where the greatest sensitivity is. And so I want to have the angle or whatever I'm interested in, be it a cyst or a melanoma, pictured on that line, on that little dotted yellow line. I'm going to use that faux speculum technique, look up. I'm looking, I have that conical bullet. Everything looks well positioned. Now I'll go look at my screen. Freeze that. Do that one more time. I want to freeze that. There, I'm right at the optimal spot. And I want to have the same orientation in my resultant picture as I'm looking at the patient. I want the left-hand side of my picture to be temporal. I want the right-hand side to be nasal for the right eye. I'm going to have the line facing temporally and going across the eye, and that will give me that same orientation. If I move to the left eye, I keep the same orientation. On the left eye, the line's going to be facing the nose, and the opposite side, where there is no line, will be facing the ear. And I have the same orientation of nasal and temporal as if I were just looking at the patient under a slit lamp. Once you look straight ahead right here, find a spot. Again, this faux speculum technique. I'm going to use this conical bullet to get everything lined up. Everything looks good. Freeze that. You can see with these examinations, it takes just seconds to do. And let me ask my patient, on a comfort scale of 1 being most comfortable and 5 being most aversive, where would you place this?
I would say 1.